Next is a very common problem we face, conversion of hip arthroplasty in failed fixation of intertrochanteric fractures. Very common condition.
Good morning to one and all. Thank you, Kanpur Arthroplasty Course Organizing Committee and Dr. S. Prasad sir for the opportunity. I'm presenting a case of 65 years old female presented with a 2 years old elsewhere managed case of fracture intertrochanteric femur, which was managed by DHS, presented to us with the pain and inability to walk and stand with the fixation failure. There was a history of diabetes mellitus for 2 years, and she was obese. Apart from this, there was no other comorbidity present. Another case, it was a 65 years old male who presented with 3 years old elsewhere managed case of fracture intertrochanteric femur, which was managed by another DHS, presented to us with the intractable pain and inability to walk and stand with the fixation failure, with no other comorbidities. In case 3, she was also a 63 years old female who presented with a 6 months old elsewhere managed case of intertrochanteric femur, which was managed by PFN, presented with intractable pain and inability to walk for last 6 months with a fixation failure. There was a history of hypertension for 6 years, and hypothyroidism for past 20 years. She was also obese. Apart from this, there was no other comorbidity present. As we know, the causes of failure for intertrochanteric fractures are multifactorial, and they are most probably contributing factors are negative anteromedial cortical support to early weight bearing or sometimes metabolic syndromes. So what do we do next? Should we go for osteosynthesis or arthroplasty? Because challenges with these are immense, which may be because of aging related or sometimes because of osteoporosis or cut through of screws. Sometimes they have associated articular damage, and because of the comminution or non-union. And these fractures are sometimes associated with the difficulty in reduction, and stability of fixation is compromised. And there is also need for some bone graft many times. So what should we do? Considering the age, the comminution, non-union, and urgency for immediate rehabilitation and mobilization, we opted for convergent hip arthroplasty, a salvage procedure. Having gone for the hip replacement in a planning, we ruled out infections, did radiographic assessment to see the loosening and non-union of proximal fragments. We did thorough evaluation of osteoporosis and anticipated all kind of complications and went into OR with all kind of armamentarium regarding removal of implant. We had all kind of revision stems and cemented, uncemented. In the case 1, we did removal of implant followed by total hip replacement using a solution stem. And we used our head as to reconstruct the acetabulum, and encirclage wiring was done. In the case 2, we also did removal of implant and used a uncemented stem. In the case 3, where removal of implant was done using, and a solution stem was used with encirclage wiring, and autogenous bone grafting was done for non-union in case of trochanteric non-union. This is an immediate post-op showing good fixation, but however, during the next 3 months, there was subsidence of a stem, which stopped, and there was, at 12 months, there was some heterotopic ossification noted. This is the immediate, this is the 2 years post-op follow-up X-ray showing some fibrous non-union as suggested by no proximal migration of trochanter, and there is heterotopic ossification. Patient can manage to walk pain-free with some lurch because of the abductor deficiency. However, this gait improves when she uses stick in the opposite hand. The rehabilitation is different, and it is individualized for every case, depending upon the condition of the patient and the stability of fixation. So what does the literature suggest? As per the literature, in intertrochanteric fracture femur in elderly, the failure rates with internal fixation ranges between 3 to 12%. However, in unstable fracture pattern, it has been reported to be as high as 56%. As per the literature, revision of internal fixation for non-united fractures has been reported to have good results in younger patients with good bone stock. However, in older patients with poor bone quality and degenerative acetabular changes, hip arthroplasty has been advocated as a salvage procedure. Another literature suggests that the converting to hip arthroplasty is a successful choice in treatment of cutout complications following PFN. Both total hip arthroplasty and hemiarthroplasty group had similar clinical results. But the greater trochanter is either not solidly healed or can be fragmented again during hip arthroplasty, thus affecting the abductor functions. Another paper, which was retrospective cohort study to see the revision and mortality of 80 patients at a 1-year follow-up, suggested that the total hip arthroplasty was associated with increased surgical revision rate. But hip dislocation was documented only once. In most cases, standard implant with large 36 mm head size was sufficient. Uncemented revision stem revealed significant higher number of revisions compared to a standard cement or uncemented stem. 1-year mortality was lower than expected. So to conclude, the convergent hip arthroplasty is a salvage procedure having good clinical outcomes, but it should be opted bearing in mind about the complications, that is increased operative morbidity corresponding to operative time, perioperative blood loss, a requirement for multiple blood transfusion, and sometimes it has intraoperative femoral fractures. Thank you.
Thanks very much. May I request the speakers to come on the stage, please, for discussion, and may I invite Dr. Sunil Kumar and Dr. Anup Agarwal as panelists for discussion. Kindly come and occupy the seats, please.